In the present day scenario, with increasing complexities in ophthalmology treatment and treatment modalities and investigations, it becomes imperative that we are aware of the patient safety and make sure that we are examining the correct patient, we are treating the correct patient, we are giving the correct treatment. So this session is about patient safety and a few places where it could go wrong and what we can do about setting things right. First call upon Dr. R.D. Ravindran, Chairman, Aravind Eye Care System, for giving the introduction.
Yeah. So good morning. Yeah, good to see some of you. I mean, it'll be good if you all know, some of you can come to the front for better interaction. So we are all a small group. Yeah. Thank you. Thanks. So, ensuring the patient safety to prevent adverse events in eye care is really important. This is a subject which is given probably the least importance in today's scenario. Even though it's very important, it can probably even shake the whole sustainability of the organization and the practice. So in that way, it becomes very, very important. So I've had the opportunity to be the chief of at least 4 of the eye hospitals now across the whole entire Aravind Eye Care system. And I always found that delivering quality, not only quality service, but also very safe eye care is very, very important. Only with that, if you are able to deliver a safe delivery, you also will have good processes in place indirectly. So in that way, it becomes very, very important, and that's what will really help in us in achieving our vision of eliminating needless blindness. Today, the modern ophthalmology or modern healthcare is really very complex. Earlier, one disease used to have one treatment. The time when I started ophthalmology practice, there was only one modality, doing intracapsular cataract extraction. Maybe there are different ways of doing ICCE, but there was only one option. But the last 30 years, it has become very complex. For example, if you take cataract today, we have at least 4 options. And each option also can be done in a different way with different technologies. Unless you are familiar with that particular equipment, you are likely to make mistakes. And you have multiple intraocular lenses, each power ranging from -10 to +40. So all that becomes very, very complex and also makes it very error prone. And if you ask the patients what is it their expectation, they really look at reliable services, appropriate cost, transparency, and they have to be treated really well during the whole treatment process is what they expect. And if you look at the docs, ask the doctors what is their perception about the quality, they really look at the effectiveness part of the whole pyramid, which is a good outcome, minimal complication. They are interested in using the state-of-the-art technology, and the safety issues are not there in the mind of either the provider or the patient. That's a real state of affairs today. So I'm just sharing this a recent article that was published in JAMA Network from across all specialties. This is from Veterans Hospital Network within America. They have reported the errors which happen in about the whole network across the whole country over a period of 8 years. And as you can see here, it is about 32 lakh surgical procedures. Of the 32 lakh surgical procedures, there were 277 errors and 206 near misses. If those near misses, if this is what they are saying, within and outside the operating room. So many of the near misses were found outside the operating room. If they have not been found, these numbers would have been doubled. And you look at what these errors were, it was involved operating on the wrong side of the patient. Maybe instead of right leg or left leg was operated. Or it could be a wrong implant where ophthalmology had a major role. And also wrong side. Instead of operating on the L4 or L5, probably they operated on L2 or L3. So vertebra. So this is a common problem. And you look at the specialties, it cuts across all specialties. But the interesting thing is ophthalmology is on the top with the highest number of procedures. There are 72 procedures. Ophthalmology and dentistry, anesthesiology are the top 3. branches where the safety errors can happen. While across all the specialties, the error is 1 per 20,000. In ophthalmology, it is 1 per 10,000. It's almost, the incidence of or error prone, the rate of error is almost doubled in ophthalmology. And they also say that, if a proper timeout has been done, they could have avoided nearly about 30% of the surgeries. There was a similar paper from the state of New York, where they've captured all the surgeries done over a period of 6 years, and about close to about 1 million surgeries, 900,000 or 9 lakh surgeries. And of that, they reported 62 cases. These are all consecutive cases. So here it's about 1 in 15,000 procedures. You have to imagine these are all not high volume centers, these are all low volume. Either the earlier the data I presented or this current data, these are all from ophthalmologists across the whole state of New York, which is wrong IOLs, wrong eye surgeries, wrong eye blocks, wrong procedures. And again, here, if they followed a set safety protocols, then 85% of these errors could have been addressed. So here it becomes very important to understand this pyramid that has been put forward by the Institute of Medicine that talks about the different dimensions of quality where safety becomes the important one. So they put the safety at the bottom of the pyramid, which is now not doing any harm, operating on the correct patient, operating at the correct site, operating on providing the correct treatment, and making the whole process error free, and also have a safe facility. So these are all what we talk about patient safety. The equally important is also patient-centered, and what we really think about, where we give importance is only about effectiveness. Okay, but if you don't have this safety and the patient-centered nature of the organization, then you will not be able to build the effectiveness or the quality outcomes to that. It's also will let us understand how the errors happen. But I'm showing you very simple examples. Some of the complex examples I did not want to bring it to you. So in a case scenario, this is one of the rare instances, a patient is advised a left eye surgery. So we have a system of putting a wristband on the left hand. We also have a system of putting a sticker. Everything was fine. The doctor's advice, the patient also wanted. But when the doctor gave the block in the operating room, he gave the block in the right eye. He also checked everything right. That left eye, everything he checked. But when he came back and gave the block, he gave it in the opposite eye. Okay, so this is what we call as an acute failure. This is a lack of presence of the person in that place. Lack of presence could have caused to this. But this is not the common cause. These acute failures which are caused by people at the end of the delivery process is not common. Okay, so it's usually related to the whole policy, the process, technology. It's all about lack of safety culture, lack of safety protocol, lack of a process to make sure that we don't do anything wrong, and also about poor decision making and lack of communication between the team. Today, ophthalmologists don't exist alone. Any practice will have about 6 or 7 people at the minimum. So many practices have 25, 30 people. Okay, so if there is a proper communication is not there, this can happen. But the people who get blamed are the people who are at the end of the care delivery. It may be a doctor or it may be a nurse. So, here, this is a scenario where there was a lapse in documentation, where a patient was advised right eye DCR. The admission counter staff, whoever is a receptionist, whatever, they generated a record for the left eye, not the right eye. She just entered left eye, not the right eye, which means, you generate everything for the left eye. Every documentation after that happens. For the left eye, if you don't have a process to check this, subsequently, you are going to end up in an error. So similarly, this is another scenario. So here a patient was seen, bilateral cataract, both eyes had a similar amount of vision, poor vision, somewhere around 624, 636. The doctor thought, the left eye cataract needs a earlier surgery than the right eye. So he advised left eye cataract surgery for that patient. Similarly, the patient was advised. And but the patient really in her mind thought she was getting the right eye operated. But when she went to the this is a free patient. When she went to the ward, every other patient told her that you are having your band on the left, you are going to get the left eye operated, not the right eye. You are saying it's a right eye. So the patient changed the wristband. Somehow she took it out and put it on the other hand. Okay, so, and then in the operating room, people should have checked, the doctor or the nurse should have checked the whole case sheet and not only just the wristband. But what happened was they checked only the wristband and they gave the block in that eye. So here, the doctor is not at fault, but the whole system. The patient is at fault. The doctor who advised was at fault. And not having a system to understand what the patient wants, the surgery. If you had somebody asked in between whether which eye you want surgery, is the right eye or left eye, and if there is a difference, then go back to the doctor and ask, clarify. That could have prevented this particular incident. So this lack of communication or lack of involving the patient also could be an issue. And again, there was we thought immersion method is the best. So we shifted to immersion method about several years back, about 8-9 years back. We invested for all of that. But during that transition period, so we had a patient with a large post-operative refractive error. What happened was the technician using the immersion method, but use the applanation mode for calculation. Okay, so that change, that lack of understanding that if you have to use, if you're using immersion mode, you have to also use that particular mode, was not conveyed that point of time. There was a lack of training which led to that particular error. So here we are talking about two things. We are talking about people versus system. Majority of the medical errors do not result from individual recklessness or the action of a particular group, and it's always caused by faulty system, processes, and conditions that lead people to make mistakes. So this also includes lack of protocols, processes, training, and the communication. So, and again, the safety errors in eye care is very common because it's a bilateral organ. We are a high volume specialty. There are multiple measurements involved, and a large number of our patients are vulnerable patients. So, that patient would not have allowed the other eye to be blocked, because if that patient is a learned patient, young patient, but when you're aged, when you have hard of hearing or dementia, all this could have happened. So ensuring safe care becomes very, very important. So we have about 3 talks. Dr. Sivakumar will talk about how do we make sure that that we implement a correct intraocular lens of the power and also the design. Because as you have seen in that particular slide, going back to that slide, majority of the errors were relating to the IOLs. And even across the system, even within our own hospital, the IOL related errors are very common, and he'll talk about it.
Other one. IOL. First, number 1. Other one, that's one, choosing correct IOL, number 1. Two presentations are there. 2 are there. The first one, choosing correct IOL, correct. Here itself, huh?
So what we are trying to convey through this instruction course on patient safety is not that you are not aware of all these procedures and processes, but it's about bringing it to your consciousness, and also it's about the necessity, importance of structuring this as a process or a protocol in your organization. How do you also share it with all your staff? Now, how do you monitor it? So that is what we want to share with all of you.
So good morning, delegates, and thank you, sir, for this opportunity to talk about ensuring safety in IOL implantation. So world over, the cataract surgery is the most commonly performed surgical procedure, and it is now the norm for patients to expect the best possible results because this is also one of the most successful surgeries. And biometry is a key to achieving these near perfect results that a patient expects from us. And there can be some biometry errors, but in case we end up with measuring it wrong or measuring a wrong patient or putting in a wrong IOL, then we are grossly wrong about it. So these are safety errors which can happen in biometry and in placing the IOL, which can compromise results and lead to patient dissatisfaction. And this dissatisfaction does not stop there. It may also result in the loss of trust of the patient in the hospital or the practitioner. And finally, the worst case scenario of a litigation can also happen. So every effort should be made to bring these errors to zero. So during biometry, what can go wrong? It could be a measurement of a wrong patient or uploading the data to a wrong patient. It could be measuring the wrong eye. The advised eye would have been the right eye. They would have measured for the left eye. There could be a wrong measurement on the machines because they were not properly calibrated, or like sir said, a wrong mode was chosen, like not choosing the silicon oil mode in the vitreous, not choosing the laser vision correction mode for measuring a post-LASIK patient. So these errors can happen when you're doing the biometry. And finally, there is always the transcription error. So whenever we are going from one machine to the other with a manual notation, there can always be a transcription error of data being fed into the wrong eye or the wrong patient. And special care should be taken in cases like the toric IOLs, where this data can actually be transcribed wrong or the axis can be totally flipped, resulting in a totally unacceptable result. Apart from this, what can happen is choosing an IOL from an already operated eye, like choosing a multifocal where a monofocal has been placed in the other eye, or vice versa. Missing out on advising a toric IOL if you notice a higher astigmatism during biometry. Missing to repeat the biometry, not following what is known as the Holliday's criteria for verifying the correct measurements whenever there is a difference between the two eyes, and missing to send patients for the references for the specialty opinion like retina for high myopia or for glaucoma for nanophthalmos. All these can lead to problems. So when we looked at for us the sentinel event, other specialties it is death, but for us it's not so. However, when we look at surgical confusions, the early on in the 2000s, there were publications on surgical confusions in ophthalmology, and IOL implantation and wrong IOL power turned out to be the most common safety error. So you can see there were so many publications. And when the NHS looked into the data, they found that there were 164 wrong implants reported between 2003 and 2010. And then it was declared as a never event in 2011, and there was a strict monitoring that followed. And then still there were 178 wrong IOL implants reported in just a matter of 4 or 5 years. In the US, there was an analysis of 106 events where the insurance companies had to pay for the litigations. And in this, they found that the wrong lens implant was a major chunk, with 67 of them and almost 63% of them being due to a wrong lens implant. So how does this error happen? We can understand a few of the scenarios. It can happen in multiple ways because it's a combination of the system and the person. So how do the errors happen? So here is a case where a doctor has examined the patient and the patient has been advised a phaco with acrylic IOL. The patient is taken to the operation theater. It's possible that a proper timeout was not done at that time and the IOL was not present there for verification. So the circulating nurse goes to the store to get it. Unfortunately, due to some confusion, maybe a look-alike box or just an error at that particular time, an aspheric IOL is handed over to the circulating nurse. This circulating nurse goes back to the operation theater with this. Unfortunately, the assisting nurse and the surgeon do not verify the lens just before the implantation, and a wrong IOL gets implanted. So this is one scenario. So in the system, what could be introduced to avoid such errors was to bring in a software in the stores in order to scan the IOL to get the correct design and the power. So here you can see in the software, when you feed the unique number or the MR number, the entire field is populated in the upper part, showing the IOL, the type, and the power to be implanted. And then down, it's not yet populated. But once you scan, you get this populated, and you can compare, as well as this also saves that this has been saved. Now, whether with this tick mark, whether you want to save this or not, and this lens can be issued. Whenever there is a difference in the power of more than 0.5, there's a warning. And if you are deliberately doing it, then you can say you want to go ahead with this, or you can stop at this and correct your error. So these are introduced into the systems. Now, here is another incident where an A scan was done for a patient. The actual length was 21 mm and the IOL power was plus 24. But while entering into the EMR, it was reversed, and the staff documented this as 24 mm, and the IOL power turned out to be, and the IOL implanted was plus 21. This resulted in a wrong IOL implant and a residual refraction. So to avoid such errors, what was done in the system was integration of all the A-scan machines with the EMR. So with this, all of this directly got uploaded into the EMR. Now, this is another incident where a patient was diagnosed with a mature cataract. An ultrasound biometry was done, and this was documented on a piece of paper. Now, whether it got exchanged or whether it was fed into the other patient, it was not known. But again, this got the wrong axial lens got into it, and the surgery was done. Now, after the surgery, when there was a refractive surprise, doing a repeat A scan found out that it was a wrong axial length entered. And then going back, it was found that another patient's axial length was entered and the IOL calculated. So to avoid such errors, what we did was initially we used to have a stamp and where we used to note down. So this also was actually a solution to the error of writing in each of these squares so that there is no illegibility in it. And then transcribing. But then we did away with the entire this thing for transcribing because this also may be confusing. And so taking out printout and transcribing. Now there's another incident. So you think that with EMR everything would be fine, but then again a patient A went for biometry in an optical biometer and it was uploaded, and a second patient also went in and it was uploaded into the same EMR. So this is this EMR now patient A has two EMRs, and according to the system, the latest calculation is taken into the printout. This printout went to the block room and to the wards and block room. Only that was verified. In the EMR, it was not verified that there were two records. And therefore, this resulted in implanting patient B's IOL in patient A. And this again was there. To avoid such errors, what we did in the system was to raise an alert from the EMR when there are two scans are uploaded. It says an A scan already exists. Do you want to measure again? Do you want to change this? So whenever this alert comes, one knows that already an A scan record exists in this EMR and can look back and correct. So a lot has been done to address the gap through technology so that a majority part of the surgical confusions and errors can be weeded out. However, finally, there is the human component which needs to be looked at, and completely eliminating that is almost impossible. So there are safety checks to avoid biometry errors. We have to ensure that it is a correct patient with at least two identifiers, a unique number or by the patient's relative's name or from where the patient is coming. There are so many similar names, similar places. Relative's name can be similar. There can be quite a few things matching between two patients, especially in a high volume setup. To ensure that it is the correct type, as sir said, always take the patient in confidence and make sure that the correct eye has been advised. The patient has understood if he wants one eye and the other eye has been taken. So ensure that it is the correct eye. To ensure a correct optical biometry measurement by seeing that the machines are updated, the machines are calibrated at regular intervals. To ensure correct biometry measurements in advanced cataracts by the immersion scan, make sure that the holiday criteria are met whenever there are differences. Make sure about biometry in correct biometry in special situations like those with post-use staphyloma, post-classic cases, or post-silicon oil cases, to ensure that there is a repeat or a differing of biometry where indicated, like again following the holiday criteria. When there are variable readings for the key readings, especially due to dry eye or corneal erosions, refer for a specialty clinic wherever it is indicated, like in high myopia to retina and to glaucoma for non-ophthalmos, to ensure that the correct IOL design has been selected. Like I said, the other eye is a monofocal or a multifocal, or now even more confusing, and EDOF. Ensure that it is the correct IOL power. Ensure that the documentation is correct, and not only the documentation, but the attachment of these sheets, whether they are to the correct patient's data on case sheet. So this is how, by checking all these, we can preempt all these errors from happening. So finally, we are in the final step of delivering safe care, and only we can break the chain at least at the final point. Once it crosses us, probably the error is done. So the role of the doctor in the ward or in the preparation room is to ensure that it is a correct patient that is being operated, and whether all the records belong to the same patient. Ensuring that it is the correct type. There are ways of marking, like a wristband or marking, double marking, and all that. Still, there is a final check there by the doctor to make sure that the entire system has worked correctly. To check whether the IOL power calculated is correct, whether the correct formula has been used for that particular case, whether all measurements are proper. Check the other eye biometry values to find any gross changes between them, compare it with the other eye. See that the proper formula for the selected IOL has been used, like the correct A constant, or in a Barrett's the lens factor. Make sure that this is done for that model and for that type of IOL. See that opinions are taken. So this is how we can weed it out even at the later stage when the patient has entered the operation room. And the final checkpoint, as recommended by WHO, is the timeout, where the patient's identity is confirmed, the eye is confirmed, everything is confirmed with the case sheet, and the IOL details, IOL model, IOL power is finally verified, not once but twice, before the surgery and just before implantation, so that we are very sure that the intended IOL goes into the eye. So one cannot stop the occurrence of errors, but the error can be picked up before it ends in an adverse event. And whenever a near miss occurs, all the more it's important that we go back and analyze where the system went wrong or where we committed a human error. And in this way, we could absolutely minimize or cut down on any of the wrong IOL implantations. Thank you very much. Now call upon our RDS sir to talk about.
Can you go to the slide sorter, that your slides?
Which one, sir?
Yeah. I just want to highlight one point for them. Can you, the slides? The slide sorter. You go to slide sorter. Is slides. Can you show slides? Yeah. Sorter. Where you have that seal, no?
Yeah. It's closing.
Then it's all right, yeah.
It's open. Yeah. So the slide sorter. Go to the max.
Yes,
sir.
Go above, yeah. Little bit. Yeah, that one. The slide number 23. 23. 23. 3.
Yeah.
So now the point here, go to the next click. One more click, yeah. So you see, earlier we used to document this, okay, and then it's also gets uploaded in the EMR. This is especially you do this when we use the ultrasound biometry. And once we do not have any evidence for the keratometer or the ultrasound readings. So when we attach these printouts also with the name of the patient, then somebody can even cross-check in the EMR whether it has been entered correctly. So one is to have these, the manual documentation. There is a way to document it so there is no error. But even whether it has been entered correctly, whether this entry is correct, all of that you need evidence so that somebody can even cross-check it. Yeah.
Thank you, sir. And dear sir, we'll now be talking about ensuring the surgery in the correct patient in the correct time and the correct procedure being done.
One more important thing about IOL calculation is also calibration of your keratometer and also our biometer. All of that, wherever, as per the thing, you have to calibrate it. So I'll just talk about continuing on that on the ensuring safe surgery. So what can, this basically about what I'm covering is what can go wrong in the operating room. So he talked about biometry. I'm just talking about what can go wrong. So this, as we talked in the examples, it could be a wrong eye block, or it could be a wrong eye surgery, or it could be a wrong intraocular lens power or an IOL design. Like he said, there are instances, at least one instance where a patient needed a multifocal, we put a aspheric, regular monofocal IOL. So it could be a wrong procedure, or could be a retained medical item. There are recently heard about an instant where there was a sponge left, MMC, mitomycin sponge, left during the trabeculectomy. So that also can happen, even though it's quite rare. So the other incidence is wrong documentation. You operate on the right eye, but you document in the case sheet as left eye. Or even when you give the discharge summary, things can also get changed. Sometimes missing documentation. A wrong surgery record. Now you operate everything well, but you record, put all the right documentation in a totally different patient case sheet. Or it could be wrong medication and the usage of expired medication in the IOL. The 72 cases you saw in that report from JAMA, a majority of that were also using expired IOLs. In a country like America, they don't have a system to take out those expired IOLs from their inventory. So that is also equally important in each of our hospitals. And again, sometimes there are instances where we are blocked, about to start the surgery, but we found that particular multifocal IOL or the toric has not come. So that also can happen, whether it's a big practice or a. So these are all some things that can go wrong, and you have to be really prepared for that. So this, to address this, we have now put certain goals. So one is goal one is how do we ensure correct patient, correct eye, and a correct procedure. The goal two is how do we ensure correct implant power, correct design at the time of surgery. Third is to prevent mortality, morbidity due to systemic emergency in the operating room. It's very important. The fourth is how do we prevent hospital-acquired infection. We are talking about endophthalmitis, either sporadic or the cluster. And goal 5 is about eliminating sight-threatening complications. So it's all about standardizing the whole process or protocols in your hospital. That's very, very important. That's what I'm going to talk more. The other thing is how do you verify and also how do you monitor. So all of that is very important if you want to bring down these errors. These are all errors which should not even happen once. Whether you are doing 1,000 surgeries or 10,000 surgeries or 1 lakh surgeries, I think we have to strive to see that not even one error happens in this. The standardization, it helps provide clarity to the staff, and it also reduces the variations and also minimizes errors. So standardization becomes very, very important. And again, we also need to, again, repeating this point, we need to really take special precautions because large number of our patients have hard of hearing. They are all above the age of 70. They are all bilaterally blind. There's a dementia, mentally challenged. There are also patients, we also handle a good number of patients who need anesthesia, especially children, and also high-risk systemic. Today, nearly 70% of the patients are either diabetic, hypertensive, cardiac, COPD, renal problems. So there is all added risk to the practice now. So the timeout becomes very, very important in ophthalmology because of all this complexity. no, right eye, left eye, ECC, manual phaco, or flax, or this particular design IOL or particular IOL. So we need to really make sure that we are correct. The whole preoperative process is complete and it's accurate, and everything is ready for you to use. So all this becomes very important. And again, what is typically advised is that you do this timeout in the operating room before you start the surgery. But ophthalmology, it's ideally you start right from the beginning as a patient enters the operating room, even before you give the block, after you give the block, before you take the patient for surgery, at the time of even putting the patient on the intraocular lenses, you should be able to do it. So, and again, so this I'm just sharing. Whatever I'm sharing here is also one drawback is that we are sharing our system. Okay, so I think you have to understand how this will work in your system, and that's really important. Okay, and one is we all have in our system we have a scan record. Now this has to belong to the patient whom we are operating. Okay, then again the consent form again will have details. This has to belong to that patient. We also have a counseling record where we make sure that the patient is aware of many things. And we have one more regular consent form, and there is an admission form. So I'm sure that many of your hospitals also may have these forms. These all become inevitable, and you have to make sure that all these forms belong to the same patient. If you just see only the front, and your consent or your IOL, whatever surgery form can be different. So all these forms have to be, so every point people are checking it, they need to check the name, the medical record number, and the eye to be operated, whether it is same, and the procedure name is also same in all the records becomes very, very important. This is again a surgery record before preoperative, with the preoperative details we again generate, because we are into EMR. The EMR can break down anytime, but it should not affect the surgery. So we also generate a preoperative surgical record which will have all these details. So even without going into the EMR, we'll be able to operate on the patient. So this is the level of complexity, one level of complexity. Okay, and again we also, this is another thing, we have a preoperative, intraoperative, we call it the perioperative record. Sometimes we find it efficient to do this, even though we have an EMR, to do a manual documentation and scan it and upload it into the thing. So all has to belong to the same patient. So when I say ensuring correct patient, it is about asking the name of the patient and checking whether the name and what the name he gives and what is in the record are same. Second, the ID number in his wristband or the ID card he has got is the same in all the records. This is what is really important, including the name, maybe, because it's a critical point. We also need to see whether his address or the care of thing, the age, all of this becomes very important. So even sometimes missing one of these elements also can result in an error. So that's about correct patient. So about correct eye. So we saw this example, I just showed you the example where the patient wanted right eye, we have advised left eye. So always, the next person after the doctor, either the counselor or the person in the reception who's making the admission, it's always better asking an open-ended question as to which eye they've come for surgery, or which eye they want to get operated. The person also should check whether it correlates with the advice given by the doctor, or with whether it correlates with the documentation, the medical record. And in the ward, somebody have to mark this particular eye. After going through these questions, mark the eye which has to be operated. It's important, and it should be done in the presence of the relatives. And in the OT, whether the correct eye is marked. Okay, here again, normally we don't encourage them asking the same question here. But here they have to see whether what is in the case record and what is marked is very important. Second, it's about the correct procedure. So the correct procedure is documented in our case in this preoperative record, in the counseling record, and also in the consent form we have taken from the patient. So in these three places, we need to see that, the same procedure is being reflected. That becomes very important. And again, the correct intraocular lens power and the design. Before you start the surgery, it is important that, the nurse and also the doctor looks at the A-scan card and the pre-operative record, which reflects the EMR and the lens that has been brought from into the operating room, whether they are all the same. It becomes very, very important. That is how you ensure the correct IOL power on the thing. And again, it's also important that you minimize the surgical complications. So two important surgical complications, which can have a very bad, poor outcome is one is a globe perforation, which is very common with the peribulbar and retrobulbar. So it's always better that you shift to subtenon anesthesia. So in Aravind, we used to have at least maybe 1 per 15,000 blocks or 1 per 10,000 blocks. But for our volume, it's a huge number. So we have decided to shift to subtenons. Since we have shifted to subtenons, there are no globe perforations for the last 7 years. There are no vascular occlusions following surgery. At least otherwise, in a system where place like ours, where we do about 100,000 cataract surgeries, we'll see at least 2-3 patients with either retinal artery occlusion or vein occlusion after surgery. Now it is not there. So the subtenons is also very important. And again, wherever the IOP is marginally high, or where there is a phacolytic glaucoma, phacomorphic glaucoma, administering IV mannitol or oral glycerol will bring down. Last year, of the maybe 125,000 cataract surgeries, we don't even have one expulsive hemorrhage. But 10 years back, we had at least maybe like 2 or 3 patients. But no, understanding that there is an issue, even 2 or 3 patients, how do you address it becomes very important. And again, having all this, iris hooks, CTR, using a higher viscoelastics, understanding where this is needed, even a pre-operative documentation will all minimize the overall surgical complications. Also equally important that all these things are available in the operating room. In all this, we need to check before we start the surgery. Whatever I'm telling you is not as we are operating, but as you start the surgery, you make sure that all these are available and you start it. And again, it's also important that you minimize the morbidity, mortality due to systemic conditions. So you have to prioritize all the high-risk systemic patients. You have to monitor these patients continually during the surgery, like a pulse oximeter or your trained nurse should be there to take care of this patient. And what is very often what we see is patients developing pulmonary edema or cardiac event is that they have not taken the medication. We have not checked it. They have not taken the medicines. So having somebody checking on that is also, so that is another separate, we have a nurse. His role is to make sure that all the systemic problems are also addressed. And, asking the patient before you start, a high-risk patient, whether they are really comfortable. So not only putting them on a monitor, but also if you can put them on oxygen, that again will help the patient, and the frequent communication, reassuring the patients, all of that. Fear is one thing that really pushes up their blood pressure also. And again, this is also important. Before you put the intraocular lenses, again, one more time you check that. The surgeon should check, show me the A-scan card, see what is the IOL power, what is the design, whether it really matches with what we are going to implant. Is all that becomes important. And there are also, when we have a PCR, we tend to change. If we have a stock of intraocular lenses available, we try to put an intraocular lens of a slightly lower power, maybe like 0.5 diopter or 1 diopter less, because we are going to put it in the sulcus. And again, making sure that when we have the second IOL, whether that also matches with that. It becomes important. You have to check the A constant. Whether if the A constant is already, not the new IOL, then you have to make the calculations accordingly and get the intraocular lenses. So, and where all we verify. Now, as I mentioned before the procedure, outside, even the patient comes into the preparation room, somebody must check it. Inside the preparation room, before we give the block, all these things should be checked. And in the OT store, or whoever is in charge of dispensing these supplies for the patient should also should check it. And before draping, before surgery, in our system, before draping, it is done by the two nurses. Before surgery, it is done by the doctor and the operating nurse. Before the IOL implantation, again, it is done by the doctor and the scrub nurse. After the procedure, again, make sure that, sometimes, after the procedure, you find that something has gone wrong. So even there is, you have time. The patient is inside the OT, we can address it. And even in the medical record, as they are coding, if they find anything wrong, so they should be able to inform the surgical team so that it can be done. So either you can have a manual checklist like this, which is also mandated by the NABH. Even though if you have an EMR, you also need to have all these things, before anesthesia, timeout before incision, and before the patient leaves. I think you have to make sure that you have it, and you also train all your nurses, your staff for that. And similarly, the same thing can be created in the electronic medical record. So I'll go. So then again, monitoring becomes very important. So errors can happen if they will not recur. No, if they are reported, if they are analyzed, and if we identify the root cause why these errors have happened, and if you address them, then we'll be able to address it. So and it's not necessary that it's important not to just the sentinel events are reported, but even near misses, like have to be reported. So we have given a list of things that have to be reported in our incident reporting system. We have an incident reporting system. I'll show you a little later, where all these things have to be even a blood pressure not documented, intraocular pressure not documented, A scan not done. If a B scan had been advised for a myopic patient, it has not been done. That has to be done. And if they have not obtained an opinion from a senior specialist, from a retina person, or a systemic patient coming without a general physician opinion, or a missing documentation, the consent not taken, wrong documentation, wrong wristband, wrong wristband in the wrong hand, mismatch of the procedure, IOL power, any process lapse, wrong eye marking or a wrong documentation, or all the sentinel events, all of this is also have to be. And this is a volume. The last 3 years, across all our this is the data for the Madurai hospital. I'm just given the OPD data. And last year, if you take the year 2022, we have seen about 942,000 patients, and we have done about 160,000 procedures, and about 595 incidents were reported. If you look at these are all related. Totally, there were 1,000 plus incidents reported, but they are all belongs to different things. If you see that, in the year 2022, this gives the data for 2020, 2021, and 2022, and the wrong eye block, not wrong IOL, wrong eye block was in one patient in 2020 and nothing in 21, and again last year we had 2 patients. There was a wrong IOL design. In the first 2 years, each year had 1 patient, and we had a wrong patient. Because the patients, both the names were same, but fortunately it was the same eye and the same power, so that it is not coming into the other one. So, and again, wrong IOL power. Last year there were about 6 patients who got a wrong IOL. And these are all like near misses, missing documentation, missing investigation, wrong documentation. These are all. I think these are all over a period of 3 years out of 450,000 procedures. So, the documentation becomes very important. So, if you are able to document, then you'll be able to learn from that, and you'll be able to put or refine your process, your protocol, so that you can avoid these errors in the next patients. So, now I'll request Dr. Sivakumar. So, if you have any questions, keep it. We'll have at least about 15 minutes for discussion in the end.
So thank you, sir. And I'll be talking about the other aspect. Till now it was on surgery. Now it is about ensuring medication safety, ensuring the correct medicines. So what is a medication error? A medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm because of that. So when we look at the issue of medication errors, I think the US has got a very stringent mechanism to capture So when you look at the burden of medication errors in the US, they had found that 250,000 preventable deaths were due to medical errors. 9.5% of the ICU deaths and high-risk deaths were due to medical errors, which included a wrong medication, a wrong dosage, a wrong rate of infusion. So it included all these in the ICU when they were under scrutiny and under the care of a nurse and a doctor. And the burden of this entirely was about $20 billion over these years. So it shows what happens when there are medication errors. So the scenario in India, there has been an evaluation of medication errors in a tertiary care hospital, and the prevalence of medical errors was found to be 14.6%. So out of the 3798 prescriptions seen, there were these many errors. And so it's highly likely that we have a high incidence of medication errors, whether we capture or not. And we also know that this is now an era of litigation, and one of the highest awards in a litigation was against a medication gone wrong, where there was a problem with the depemedrol which was prescribed, and 11.6 crore rupees was the amount that was awarded by the court to the patient. So where does this error occur most frequently? In order of frequency, it is first in ordering, or rather the writing the prescription. The second is actually in administration, where a wrong drug or a wrong dose or a wrong route is selected. Then comes dispensing, where the patient is taking it from the pharmacy. And then finally, when we are transcribing this. So these are all the sources of errors, and the most common is of ordering. So what can go wrong? It is a wrong medication that may have been advised, a wrong medication being dispensed. So this can be totally because of not of giving another drug belonging, than written in the prescription, or the prescription itself could have changed hands between the patients. So it could be a wrong prescription, or the prescription could have been handed out to the wrong patient. So finally, the patient lands up with a wrong medicine, wrong medication administered because of illegibility in the orders, or because there was an error in hearing. So there are verbal orders being issued, and when verbal orders are told over the phone, then there are all the chances of getting a wrong medicine and administering a wrong medicine, administering the wrong route or wrong dosage. It can also happen that expired medications, if not checked, can get dispensed and administered. And finally, there could be adverse drug reactions which need to be monitored and which need to be reported. So in detail, when we see how can these errors happen, that can be a wrong prescription, a totally wrong drug, lack of concentration, and a wrong drug is written. A wrong dosage. So for example, we have an epafenac in 0.1 concentration and 0.3 concentration, former three times a day and the latter once a day. There could be an interchange. There could be a change in the dosage of 0.3 given 3 times. Wrong strength written, wrong strength of especially the anti-glaucoma medications. A wrong duration, or duration not mentioned at all, like steroid drops, the patient continues putting it for a long time, or the prescription is handed over to a wrong patient without establishing identity. In wrong dispensing, again, there could be because of an illegible prescription. It can happen because the pharmacist does not understand and presumes that this should be the drug which the doctor routinely writes. Misunderstood oral orders, this is very common, where orders are issued when you're in the OT, orders are issued when over the phone when you're outside, and then something has to be given to an indoor patient. And there's a mix-up due to look-alike and sound-alike drugs. So that is one major factor where there can be an error suddenly in giving the medicines. And expired drugs, if not sorted out, can be dispensed. And a wrong administration can happen in the form of a wrong drug. It can happen with the wrong dosage. It can happen when it is given by the wrong route, like intravenous instead of intramuscular. and at a wrong rate of administration also, where an infusion has to go slowly. If it is given in a full flow, there can be a problem to the patient. So to give an example, this was an incident where a 1-year-old baby was diagnosed with congenital glaucoma, underwent an RD implant, a glaucoma valve implant, and the patient was actually advised a cyclo 1%, which meant a cyclopentolate 1%. Now, the error starts here. The source of error starts here, where it was cyclo 1%, and it was written in a short form. In the pharmacy, the patient received cyclomune. So this resulted in cyclomune being dispensed. So how can you avoid these type of things? And this is also required by mandated by the NABH for segregating the look-alike and sound-alike drugs. There are quite a few in ophthalmology which similar packages which look similar, and some of the drugs which sound similar. So here anything with an added letter like an added T or an added S or an RT, they're all looking similar. The packages are similar, very minimal change in color, and they are all look alike. There are also some which are like sound alike. Like I'm sorry to take brand names, but it is like Lopress and Lubrex. So one is a lubricant. The first one is an anti-glaucoma drug. Now instead of Lopress, somebody takes a Lubrex. There is no harm, but the patient isn't cured at all. So these are all the instances of a look-alike, sound-alike mistake that could happen. So we need to segregate these into two shelves and with the color coding in the cupboards and with the label that they are look-alike and sound-alike medications. And they are best kept at the two ends of the pharmacy. Like you can see here, it's at one end and the other one is at the other end, so that there is no mistake in taking it. And you can also cut down the number of your look-alike and sound-alike drugs by cutting down on the numbers which look alike, on actually procuring those drugs which have a sound-alike or a look-alike names. And then this should happen at all points of storage. So this should happen at these codings should be there everywhere, even in your crash cards, so that at that time there's a careful checking that the proper medicine is taken up and proper medication is administered. Now here also, like there is another case where there's a 60-year-old female was diagnosed with sympathetic ophthalmia, and oral steroids were prescribed in tapering dose, was asked to take endoxan 2 tablets per day and Visalon 5 tablets per day. A week later, there was no improvement in the patient's condition. So when the patient was queried, it was found that it was in the reverse, that endoxan was taken 5 tablets a day and Visalon only 2 tablets per day. And so there was some error in communicating to the patient or in writing down the orders. So all patients should be counseled back after coming from the pharmacy in the clinic, especially when you're dealing with high-risk medications. And it is good to prevent a high-risk medication to register in order to track back who has ordered it and to see whether the proper counseling was given or not. Storage also requires to be separate for high-risk and emergency drugs. We're good to have a list outside, good to have a stock for these, and also to have a double check before this is being dispensed. In another incident, a patient was advised injection Ozurdex, and during the counseling, instead, Tricort was selected on the electronic medical records, and it resulted in a wrong intravitreal drug administration. So how could this have been avoided? You have to check the doctor's advice, check the patient's preference based on affordability to see what the patient can afford. And again, just like surgery, before injection, confirm everything. Confirm from the case sheet what has been ordered, from the EMR what has been ordered, or check the patient's identity, confirm the billing, confirm everything, and then administer. One of the commonest errors in administration is administering a drug to which a patient is allergic without knowing it or without checking it. So the most common example in our setup is dilating with the drops to which the patient is allergic, and that is mostly tropicamide. So how can we avoid this? We need to first, we should have a history of allergies taken, and once we know that there's an allergy, we highlight it in the EMR. We write it also on the case sheet. We stick a sticker onto the ID card of the patient, and a sticker if it's on the record, if it's a physical record, and then so that every time the patient comes, it can be known and it is not dilated. So all these can be seen that the gap can be addressed with technology, but however, as I said, the human element is the most important. The doctor's role in ensuring the correct medication is to see that the correct drug is prescribed based on the diagnosis, mention the dosage, frequency, and the duration. Give the correct eye. If it is only for one eye, write the correct eye in the prescription. Advise the appropriate review date until when the patient has to put it, and hand over the prescription to the patient, preferably while the patient is still sitting with you. Ensure that it is the correct medication in case of any high risk drugs or steroids. In prescription, always mention the tapering frequency. Always ensure proper counseling about the medicine whenever it is a high risk. And investigations which need to go with it, like for steroids, you need to have the baseline IOP and the blood sugar, and monitor the same during the follow-up to see if there's any change. And ensure that you mention the review date and ensure that the patient follows up with you. So for ensuring correct medication, we need to have make sure that it is the correct patient, it is the correct drug, it is the correct route, it is the correct dosage, it is the correct frequency, and to the correct time. Thank you. So I call upon Sir to talk about establishing the safety culture.
Thanks, Dr. Shivakumar, for thanks, Shivakumar, for this your talk on the medication. The medication is very important. A lot of things you all must be aware, but creating a system, a process, making everybody aware of that is very important. That's where the leadership role becomes important. How do we develop that culture of safety within the organization becomes very important. That's what I'm going to share here is our experience, what we have done within Arvind. Okay, and probably some of these learnings, the principles, what I'm sharing with you, probably you can take it, modify it, adopt it in your own system. So, the safety is a way of thinking and acting wherever we are, whether it may be in our workplace, it may be at home, or it may be leisure, wherever we are. I think safety becomes very, very important. And it's also everyone's responsibility, not just that one person. And everyone should feel comfortable to report any safety issue within the organization. So if you don't bring that culture of reporting, it's not going to be reported, and we are not going to learn it, and somebody else is also going to make that mistake again. And the safety should become part of organizational culture, and investing in the human capital is very, very important. And as I said, these are all just some of the principles. One is, first, you need to create awareness about patient safety within your organization. So we were doing it at some level from 2005, 2006, making sure that we don't do a wrong eye surgery or a wrong procedure, we don't implant a wrong IOL. But some point of time, we thought we should have a system-wide a discussion, and wherein we asked people to bring all their case records where something went wrong. So from the 5 hospitals at that time we had, they all brought those case sheets where they did something wrong. And these are openly discussed in a meeting where we had about 100 plus people from the system. So here we also opened up them to understand what the quality really means. And basically the whole discussion was how safe or unsafe is our hospital. Second, openly sharing what goes wrong in each of our hospitals. And we did a kind of root cause analysis, why that particular error happened in that particular facility. And initially we introduced the Joint Commission International Patient Safety Goals on Communication and Patient Satisfaction. That is how we started in the year 2011. But we also made them know that to err is human, and and this is can happen. This will keep on happening. But its important thing is how do we reduce it and minimize it. So that's the message we gave. Since then, we must have had about 3 or 4 such 2-day or 3-day meetings. The second is, so not only telling them they have to report, but we also need to create a system for reporting. So we said, anybody can report anything goes wrong. So initially we started with the paper form. We introduced the paper form, which was finalized during that meeting, and it was implemented across all hospitals, but nothing happened. Nobody reported. But once we went into our intranet system, which at that point of time we had, and it was available everywhere because the intranet is available everywhere, all these systems. And anybody can report. This is incident reporting. So they click on that. If they click on that thing, so then it will produce an incident reporting form. So the incident reporting form is very simple, and it is anonymous, and anybody can report it from anybody. But we also encourage them to put their name, and people whose name who can be contacted, so that we'll be able to address that these issues in a much better way. And this is, as soon as somebody reports an incident within the system, the chief medical officer of the hospital gets that that message immediately. And also the person, the safety doctor, one of the senior medical officer who's in charge of the safety, and also the manager gets the thing. Here, for example, this is a report where they reported there are 2 patients with the same name and initials were posted for pterygium surgery on the same day. During counseling, root cord was interchanged. One of the patients were known to a senior staff, and due to this confusion, the surgery was delayed and was done at 4 p.m. Both the patients underwent correct eye surgery and had uneventful post-operative thing. But so here nothing went wrong. But the delay, the confusion, the change, this is like a near miss. This was kind of reported. This would have helped some way to address this also. The third thing what we did is initially we shared the kind of a borrowed safety goals from the JCI, but here we came up with our own goals of 10 goals, what we really are expecting to be prevented, to be addressed within the organization. So we listed 10, but but each of these goals, probably to have these 10 goals, probably we may have about 50 or 60 protocols and processes in place. And because it varies for area to area, because we have to make sure that starting from outpatient department, biometry, counseling, admission, ward, in the surgical, the stores, everywhere this has got an implication. So we have not only defined it, but we also have created protocols on that. And we also made people understand that the whole safety is related to the work process. So creating systems to address that. Now, what we do is actually what contributes to the error. So we need to make sure that we have systems that will enhance the patient safety. And again, in our organization, it is also a little bit complex because each person does one activity. Like somebody does refraction, somebody may do an investigation. Even each investigation is done by a different person. So there are also multiple handovers of the patients from one person to another. So there could be errors relating to patient identification can happen. That's why I was telling you. So what I'm discussing here, sharing here is all related to Aravind. But each of your organization can have a different challenges and different type of errors because it's all related to the way you have structured your workflow and the process. And we ensure that that the patient is identified using their ID card. They need to check the patient name and they check the ID number in their ID card, and also with the case record. This is the first step they need to do. But in the inpatient record, they may not carry the ID card, but they'll have a wristband. That is what they'll use for checking at every point. So this is what I've showed. So this is a root card. Whether the root card matches with the ID, whether all these two matches with the EMR which they open, they have to check. And again, for the inpatient, they always check with the with the name of check the name and also check the ID with the wristband. And again, the timeout and the safety checklist becomes very important. As I mentioned earlier, check the patient's name, the match the medical record number, check whether the marked eye is correct, all of that. So all this we put in place. Then we also found calibration to be a problem. So we brought in the calibration which is done as per the requirement for all the equipments across the system. And again, the training across the system, developing the protocol, preparing the training material, Word document, and also posters. This is the protocol. This you can see. This is for the biometry. It's got about 50 slides going into all the details, how the whole process have to be done. So this is the presentation we have for the biometry part of it. So the biometry for a tertiary hospital, secondary hospital, if they use a IOL master, if they use a UBM, the ultrasound, so at least there are 4 or 5 protocols. If they are using a toric IOL, then there's a separate safety protocol. If it's a multifocal IOL, there, because we have to make sure that none of the procedures are also missed. And again, we have these posters developed which are put. This reflects in brief the whole protocol which I put up in the A-scan room. We have similar one for refraction. We have similar one for optical shop, medical shop. So they also have these posters and also videos for easy understanding. Otherwise, these are all very monotonous, very difficult to understand for the people. We have also developed videos for that. And also we define what can be reported by the biometrist. If the biometrist should report if a wrong eye has been advised by the doctor. So because the first question he has to ask whether you have been advised right eye surgery. If the patient says left eye, then the patient has to go back. Okay. So because the doctors make the mistake of saying something and entering something else. The wrong diagnosis, interchange of diagnosis between the eyes, missing of silicone oil in the diagnosis. So this person is reporting what the doctor did wrong. If the doctor has missed a multifocal IOL in the other eye, yes, he'll report it. And then it's also important that we share this. Like the other report I showed you, this is for the year 2019, where we had seen close to about 9 lakh patients, and we've done about 1,68,000 surgeries and 492 errors. So here you can see that there was one patient who had a wrong IOL implanted design. There are 3 patients who had a wrong eye was blocked. And there was an error of patient identification error process. The rest of the things are all near misses. These were all, if we have not picked it up, many of this could have resulted in a wrong eye surgery or a wrong block or a wrong intraocular lens implantation. And again, it's also important that you constantly, as you get these reports, do a root cause analysis, understanding what's happening. Still a challenge for us is a wrong eye blocked. Okay, so we, instead of one mark, we put a double mark. Even that double mark didn't happen. Then we made sure that one person, when a doctor gives a block, a person must stand with the patient, because this wrong eye block is picked by the doctor in the operating room, where there are 2 or 3 people are involved, whereas the block is being given by one person. So we had another person stand to make sure that the doctor will not do something wrong during the process, because the first victim is the patient, the second victim is the doctor who did that. So he also suffers. We make sure that that doesn't happen. And again, the example there, so we have some documentation. How do we verify that? So we have the evidence to verify something. We have, say, a protocol, whether this work done by, we are saying about the doctor's work has to be verified by the biometrist. So the biometry work, he can do a transcription error, whether he has transcribed correctly into the EMR. So we also have some evidence now. And again, using technology to promote safety. So, we used to say, that, you have to get the ID card, you have to check the number, only then you should write. That really doesn't happen many times. So now, if they don't put the last 3 digits of the medical record number, which is only with the patient, only in the ID card, the medical record will not open. So we brought in that safety feature. And again, this is doctor saying right eye, entering left eye is common. At least one person will do it at least 1 or 2 times in a year. So now it will ask whether you advise the right time. So he has to say yes, only then it will move on to the next. And again, as Dr. Sivakumar said, so as they scan the IOL has to match with the advice. So the design has to match, the power has to match. Only then the person will be able to dispense it in the stores. And again, the surgical safety checklist. And again, it's also about, like when you want to develop a culture, it's also about developing a kind of a shared leadership. So today we have, as you can see here, for the hospital in Tirupati, there are about 4 people who are involved in making sure that the medical records. Medical record, the safety part is entering the correct name, correct address, correct phone number, correct the care of addresses, all of that becomes very important. So something similar, we have defined what it means, safety for each of the departments. And these are all people who have been have to take the accountability. And these people come together at the system level with other 14 hospitals, and they form a team, and there is a leader for each of these, refraction, medical record, and all of that. So, and they meet on a regular basis, and they discuss, share what went wrong in each of the hospital, and we are able to learn from that and make sure that the same mistake doesn't happen in another hospital. So, to conclude, so this is a data I'm sharing from the Rotterdam Eye Hospital. This is a period 2000 to 2009. As you can see, these are all wrong eye surgeries or wrong implants. Initially, the first 4 years, from 2000 2003. So these are all low volume. They are doing only about less than 10,000 surgeries, and you can see. And in year 2001, for every 1,000 surgeries, they had one wrong event. And but once they woke up and put in place a process, this number reduced, but the near misses increased. People are making mistake, but now there is a protocol and process to pick it up so that you avoid an event. So this error we may not be able to prevent from people making it, but we have a system, somebody else will be able to pick it up. So I'm just emphasizing this point because it's not a problem of Aravind alone. It's a problem everywhere. It's not a problem of a place like a high volume place, hospitals, but even in a smaller practice, this can happen, and we also have to be aware of that fact. And again, to conclude, so ophthalmology, as I said earlier, it's a bilateral organ. So ophthalmology has got the highest incidence of wrong, all the sentinel events across all specialties. And each disease has got a multiple treatment options, and there is a lot of multiple measurements are there, and we are also handling a lot of vulnerable patients. So all of that makes ophthalmology becomes error prone. So you have to identify areas where errors happen in your practice. You have to understand how they happen, and you have to reduce the whole complexity and develop reliable process for each of those area, and create independent checks. Anybody has done a work, somebody at the next level should check that work. Otherwise, it should not move to the next level, or they should not perform anything. And create a culture of safety through role models. I think that's the main work of the leaders of the organization. So thank you. Yeah. So we open it for any questions or anything you want to share if something has gone wrong in your hospital or organization.
All the presentations very nice. The meeting which the charges are holding for the safety point. So this is a type of medical auditing, like they are seeing the documents, or what is happened that they are discussing.
So whatever errors that were reported in their hospital, for example, counseling, if there is some error has been reported, then they discuss about those errors.
So medical auditing.
Yeah, it's like you can say medical audit. So, yeah. So we have the details of the patient in the EMR. So you have the name, what is the intro. Yeah, you go and scan it. We have we scan it, we have scanned them. This is aspheric. As per the EMR, aspheric lens means what? Acrylic lens means what? So we have tagged that to the thing. So every IOL that comes in, the box is scanned before they go to the. Yeah.
So we have this problem of, sometimes we give a wrong lens to the patient because there is an inventory for the day in that operation theater of intraocular lenses, and there are patients. So the names overlap and something. So we have misses there, yes.
Yeah. So we have developed a system where the design and the power have to match before the storekeeper can issue the IOL.
No, in the OT
The
itself.
OT itself.
Because there are about 30 surgeries to be done. So there is where the mistake happens.
Yeah.
So
mostly.
one of the things what we have done in our hospital was, especially like you mentioned, it's a very common problem, I think, in every hospital where you have similar name, including similar address also. They've come from the same town. So then it becomes really issue. So what we do is the previous day, what we do is we look at the OT list. First, we mark out the names which are very common first. So that day, the next day, before everyone starts, it's already ticked. Okay, these are the two common names. Be aware, be aware, be aware. And plus, the checking of the lens happens at least at 4 places. So what happens? At least if two people also do the mistake, at least the third or fourth person will pick it up. So from the time, from the stores of the OT to, the counter person, then the block person, then inside the OT. So all 4 points, the lens is checked, eye is checked. And also when in terms of identifying the eye, what we do is one of the tricks we have adopted is the hand wrist. The hand band is put in the eye which is operated. So one is, if it is right eye, then the right hand is put, left eye, left eye, left hand. And also we color code it. Right eye is red color wristband. The other eye, if it is the left eye, then it is yellow color. So it's just that we are giving more and more visual clues so that if someone forgets to do, because we create processes, but over time everyone becomes lazy and then they start skipping some few steps on the way, just to create more visual and more steps so the people don't miss it out.
Yeah.
Thank you.
Yeah, but what you say is important, to bring that awareness and a differentiation. But exactly checking as we are making this transition to the digital, world. So with another 4 or 5 years, everything is going to become digital and everywhere, and it's going to become very, very complex, and the chances of making mistakes is going to be very high. Yeah.
So thank you for the great IC. Continuing with the same point, I'd say that as Sir also said, that the ultimate onus is on the doctor. So although my setup is not a very high volume setup, so suppose I have 10 surgeries in a day, and there might be 2 or 3 patients who are named Fatima Begum. So before I start the surgeries, I go to the ward, check with torch all the patients, and when I come back, in the case sheet, I see the A scan again, and on the lens box, I mark, so according to left eyes and right eyes. Suppose that there are 3 right eyes and 7 left eyes in a day. So I try to do all left eyes together and then right eye so that we don't have to move from here to there. So on the lens box, I write the name of the patient.
Okay.
So Fatima Begum 1 is the first patient whom I'm going to operate. So on the lens box, I number the order of surgery also. So 1, Fatima Begum, that means this Fatima Begum is going to go first.
Okay.
So on the lens box, so before the lens box is opened, the running nurse announces that 1 Fatima Begum, and then we take the lens. So I think people who don't have very high volume setups, doctor can write the name of the patient on the lens box along with the serial order in which that patient is going to be operated.
Yeah.
So that is one way we can
What
avoid.
it's a great idea, but it's always better to have 2 or 3 identifiers, not just the name alone. On the serial, when you are going to operate, maybe like the medical record number or address, something, 2 or 3 identifiers should be there, not one identifier. Yes, doctor.
Yeah, Thank you for great talk. And what we are doing, that right in front of the surgeon, we have a big screen which displays the EMR. You have the portrait of the patient. If there are patients with two names in the premises, there is a big red block which comes that there are two patients of this
the
name
same.
in the premises, both in the OPD and in the OT.
Okay.
And it becomes very clear. And then there is on the screen comes 3 points, that these are the 3 points you are going to check. As you said, it's very valid. It has to be minimum 3 identifiers.
Okay.
Then all the surgical parameters are there, and if the surgeon wants to go through any of the pictures or biometer or anything, again, all that information is available to the surgeon right in front. So visual, as you are saying, is very, very important.
Very important.
Thank
Yeah.
you.
Thank you. Thanks a lot. So, I mean, I really thank, to see all of you. We have good response for this IC, which I thought, not many people will be attending, but good to see a good number. But this is an area of real importance, especially people who head the organization or who got a practice. Even, because especially for people who operate in multiple places, where there are different cultures. But every place where you go, you have to make sure that your culture, is there, is practiced the moment you are there. Thank you. Thanks a lot. Thanks, Dr.
Thank you very
Shivakumar
much.
as well.